discussing on pediatric ophthalmology and strabismus. So can you guys hear me lang, loud and
Yes,
clear?
Doc.
Okay, thank you. Sige, so ready na? Are all set or napay-uban wala naka-connect? Shall we start?
Yes, Doc.
Sige. So, good afternoon again. In pediatric ophthalmology and strabismus, it's noted that child is very challenging. Symptoms are often unspecific and information is hard to convey, especially those who are illiterate na or pre-verbal children. And uh, examination techniques require modification. So we have to adjust depending on the situation. So the examination, so every newborn should be assessed for normal, symmetrical, external ocular anatomy and for red reflex. So I hope at this time you already uh, remember na how to examine the adnexal part of your VATEF, and also for your fundus, you have to be able to identify your red reflex already. So there's also full ophthalmologic assessment if any abnormality is identified, and further examination for those non-ocular abnormalities being identified, like systemic abnormalities, physical malformations, etc. So as a child grows, the visual system continues to develop as well, and many congenital defects can be mirrored or seen in the eye as well. So uh, if at first um, pre-verbal area, the at the pre-verbal era, your patient would have a visual acuity that we record as fixate or as fixates or follows. So fixates and follows. If the patient is able to uh, fixate onto the object that we are stimulating, and if the patient is constantly following the object being identified, then around preschool, the patient is expected to have near vision around 2100, and around school age, patients can be at 2050 or 2040, and then at um, school age school age to teens expected that they are reaching towards the 2020 vision. So how do we do the VATEF for your pedia patients? No, so we refer to this pediatric exam in basic eye exam. So this is how we usually examine your patients. So we expect that um the normal values for your pediatric patients differ for those, of course, in adults. No, so in terms of globe dimension, the weight would be lesser, so 2 to 3.4 grams as compared to 7.5 grams in adults. The volume would be around 2 to 3.25 cubic centimeters as compared to 6 to 7 cc in adult. The axial length, of course, is smaller. It's 17 to 17.5 millimeters, and it reaches adult proportion by age 5, which is around 22 to 24.5 millimeters. For the corneal diameter, it's normal to have 9 to 10.5 millimeters as compared to adult size of 10 to 13 millimeters. The EC depth is 1.8 to 2.4 as compared to normal adult of 3 millimeters. So pediatric common diseases. So pediatric diseases are similar to those found in adults, like You have your nasolacrimal duct obstruction, the cystitis, orbital cellulitis, preseptal cellulitis, and the list goes on. There are variations in terms of anatomy due to the developing eye since it's smaller compared to the adult size. There are also variations in complications, the management, and etc. Some of these diseases have been previously discussed, but it will be reviewed in this section. So we'll start with ophthalmonatorum. Uh, it is the conjunctivitis of the newborn during the first month of life. Remember, it's the first month of life. So anything that could cause conjunctivitis at the first month is considered ophthalmonatorum. Risk factors, you have passage to birth canal, you have premature rupture of membranes, inadequacy of eye prophylaxis, exposure to infectious organisms, poor hygiene, and maternal infection. Etiology could be chemical, bacterial, or viral, depending on the etiologic agent. Differentiation sometimes possible according to the timing and presentation. So timing of presentation and how it presents. Essential could be due to just conjunctival smears and culture. And antenatal could be diagnosis and treatment of maternal genital infections, should prevent many cases of this neonatal conjunctivitis. For chemical, post-delivery eye prophylaxis for gonococcal infections. So initially, we use silver nitrate for prophylaxis. However, it's already abandoned and replaced with erythromycin eye ointment due to instances wherein silver nitrate causes significant cases of ophthalmonatorum or conjunctivitis. So now, the standard protocol would be the use of erythromycin ointment with lesser incidence of having conjunctivitis for eye prophylaxis. So for your bacterial conjunctivitis, it could be either from a Staphylococcus, Streptococcus, Haemophilus, or any other microorganisms. So these three are the most common etiologic agent. It also require topical antibiotics. So you have your erythromycin eye ointment. Um, other um, other etiologic agents that could cause the most serious form of bacterial conjunctivitis is caused by your Neisseria gonorrhea and your Pseudomonas. It has this potential for corneal damage as these microorganisms could cause uh, fast they call this a quick corneal melt. No, so Neisseria gonorrhea will have this copious eye discharge that interacts with your um corneal enzymes, thus in turn will melt your cornea. Pseudomonas also, since they are gram negative, it will um it will eat at all the proteins and your of your cornea. No, so it's very potent microorganism that could cause corneal melt. We can also encounter patients having chlamydia trachomatis, where patients with infected mothers. So it is the most common identifiable infectious cause of neonatal conjunctivitis. Remember, since it could be found at onset of 5 to 14 days after birth. So it is passage to birth canal. So it's the risk factor for this type of etiologic agent. So if the patient's mother is already infected, so chances are the patient could develop chlamydia traumatis na ophthalmonatorum. So it's average seen usually around 1 week of birth. It is presented with mild hyperemia and scant mucoid discharge. and there would be a characteristic inclusion bodies in conjunctival smears. Systemic erythromycin is more effective than topical therapy. So in this patients, even though also we're also giving topical erythromycin, um, we also up to give systemic erythromycin or the oral erythromycin for this case, or IV and erythromycin for this case, since it eradicates concurrent nasopharyngeal carriage. So Chlamydia trachomatis can also coexist with gonococcal conjunctivitis, since both etiologic agents are uh, somewhat uh, coming from a sexually transmitted disease or infection. So for your gonococcal conjunctivitis, it's the most serious form is caused by your Neisseria gonorrhea, and it occurs within 3 to 5 days after birth. So it's also seen around the first week of life. So it is presented by marked chemosis, lid edema, copious mucopurulent discharge, corneal ulcer, which causes your corneal perforation, and eventually endophthalmitis. So if you noted very copious mucopurulent discharge from a baby, so you have to really suspect a gonococcal etiologic agent. So it is it is not the typical discharge that the patient or your babies have. No, so it's really copious. So think of gonococcal conjunctivitis. Irrigation with normal saline to remove the discharge is a must. Since it's very copious, you have to prevent corneal perforation or prevent corneal ulcer formation. So we have to remove the discharge in contact with, or we have to lessen the contact time with your discharge to your cornea. So we have to irrigate the normal saline to remove the discharge as frequent as every 30 to 60 minutes. No, since it's really fast na in producing your pus. So you have to, or producing the discharge. So you have to do irrigation as frequent as possible. For the treatment, we give ceftriaxone IM or IV, and the mother and the sexual partner should be treated as well, since it's a sexually transmitted infection. Next condition would be your congenital nasolacrimal duct obstruction. It's common in It's common in children, especially less than 1 year old. Another frequent cause of discharge and tearing is this condition. So if you suspect that the patient is having a congenital LDO, you can also expect the child of producing discharge, eye discharge and tearing. It's not just the conjunctivitis. And since infants are relatively immunocompromised, their immune system are still building up, infections have the potential to spread, causing further problems such as orbital cellulitis or sepsis. So it's important to assess the nature of the discharge and tearing. So for for babies, their lacrimal drainage structures begin to form by fifth week of gestation, and canalization begins by eighth week and continues until birth. The opening between the nasal lacrimal duct and the nares often not patent at birth. So we have to we have to inspect whether your child has a patent duct before we would diagnose the congenital nasolacrimal duct obstruction. So the pathology would be there would be persistence of a membrane at the valve of Hasner. This is the site of obstruction. It's called the valve of Hasner. So if you could encounter a patient that complains of or being complained of having epiphora, patient is also having crusting and yellowish discharge, then think of congenital nasolacrimal duct obstruction. If this condition, no, if this condition is left, if this condition is left untreated, it could uh it could potentially lead to orbital cellulitis, no, since it's potential area for breeding of your microorganisms. So you have to we have to we have to identify the cause, no? So since your your children are still developing, as what mentioned here, canalization begins by 8 week and continues until birth. So we expect every child to have an immature nasolacrimal duct before before the first year. So um the observation for the management for this is observation for less than 1 year, since 90% of those having non-patent nasolacrimal duct would just resolve on itself, no, by around 1 year, and then 60% resolved by the second year. However, if the patient had symptoms after the first year, we can opt to do regular massage or sac massage, and we treat with erythromycin and ointment to prevent infection. No, and then if after the non-invasive interventions such as your massage and antibiotics, if still the nasolacrimal duct is not patent, then we do the probing. We insert a probe, a metal rod, onto the patient's nasolacrimal duct, and we insert it on the patient's uh we insert it in the patient's nasolacrimal around the inferior meatus, no? So we check if there would be restrictions, or there would be limitations, no, upon the passage of the probe. Though this condition, your nasolacrimal duct obstruction, has a slower resolution as the time goes by. So we usually perform those invasive procedures after we have exhausted all the non-invasive procedures such as your massage, no? And then we then do probing, and then we also do perform surgeries, and eventually the DCR procedure, the cryorhinocystorenoscopy, no? So we make a hole na to bypass the duct, and make a connection from the punctum going to the inferior meatus. So the condition does not improve over time, and after all um measures, after also the patient already had probing, another another option could be the ballooning before we perform the DCR. We inflate the duct with a balloon, and sometimes the benefits of this maneuver is the and possibility of further creation of fistula. No, so it has its own risks also. Another interconnected condition would be your dacryocystitis. So in relation to the lacrimal drainage system, dacryocystitis can also occur in children, as uh, their nasolacrimal duct are still small or still developing. No, they can be prone to lodging of the microorganisms. So infection of the nasolacrimal sac could be either caused by your staphylococcus, streptococcus, and Pseudomonas. In congenital NLDO, organisms are usually the normal flora. So it is typically low grade. The Dacryocystitis is typically low grade. It results from stagnation of bacteria in the lacrimal sac, and pressure over lacrimal sac produces retrograde reflux of mucopurulent discharge. The management, we usually advise the patient's caregivers or the mothers to do warm compress every time there would be swelling up around the periorbital area. Apply warm compress for around 15 minutes, and we give oral antibiotics. Um, we also treat it with topical antibiotics, however, it is of limited value. No, medication may not reach the site of infection because of stasis within the drainage system. Uh, that's why we usually prefer the oral antibiotics is more effective. So incision and drainage for localized abscess, we also perform the cryocystorhinostomy for the nasolacrimal duct obstruction. Next would be your cellulitis. So at this point, you have to you have already discussed this, I believe, no? So you have to uh, distinguish the difference na of your preseptal versus your orbital cellulitis. So if it's infection anterior to the orbital septum and spares the globe, it's preseptal. Examples would be from your skin trauma, the largest risk factor. There would be history of skin trauma, and the sorry, excuse me. And the most common etiologic agent would be your Staphylococcus aureus. For your orbital cellulitis, if there is infection now posterior to the orbital septum, then it's post-septal cellulitis. So it's already considered your orbital cellulitis. The most common cause would be your sinusitis, also caused by your Staphylococcus aureus. Usual findings, usual, usual findings for your preseptal cellulitis include eyelid edema, erythema, pain, and fever. Now, it mimics the initial stage of orbital cellulitis. However, if there's orbital cellulitis, aside from those findings mentioned, there would be an additional proptosis, chemosis. There also limitation of the EOM or the extraocular muscle movement, and your vision is already affected. So patient would complain of blurring of vision already. So this would mean that the infection has already traversed the uh, inner side of your orbit. So it's already orbital cellulitis. Management for preseptal would just give your oral antibiotics, your supportive, give paracetamol for fever, and close monitoring. However, your orbitals, it's considered a critical disease, no? So we usually admit patients for close observation, closer monitoring, and also for administration of broad spectrum IV antibiotics. Blood culture and conjunctival swab are also done during this admission as definite medical management is always a must for this condition. The most dreaded complication for this orbital cellulitis is death. So it is really considered a serious or critical disease. We also have to refer the patient for ENT consultation since the most common cause would be from your sinusitis. It could be from your ethmoid sinusitis, ethmoidal, no? Ethmoid since is the nearest to your orbit. And then we do surgical drainage if there would be abscess formation. Next would another common in children would be your capillary hemangioma. This is the most common benign tumor of the orbit in children. It is composed of anastomosing vascular channels and 30% at birth, usually noticed by first year of life. It is more common in females or girls. Excuse me. Hello, good afternoon. Hi, sorry. So it could also be described as a strawberry nevi, so it's how you see it, the lesion, it also looks like a strawberry, so we call this as strawberry nevi. 90% apparent before age 6 months, and some enlarge rapidly during the first year of life. They regress slowly over 6 to 7 years. However, for those patients that are symptomatic or at risk for um astigmatism, significant astigmatism due to the pressure exerted by the mass. Sorry guys, not may titawag. So, saan na 'to? So, some regress slowly over 6 to 7 years. However, for those patients na with significant pressure, no, so to the size, no, and significant threat to the site, like it's pressing onto your cornea, causing significant astigmatism, then we perform intralesional injection of your steroids. So, for smaller for smaller for smaller lesions, we just observe, no, as 30% resolved by 3 years old and 70% resolved by 7 years old. However, as what I've said earlier, if the patient uh is if the mass is threatening the patient's visual acuity due to the pressure exerted by the mass, no, it deforms the cornea, it causes astigmatism. Then we then resort to giving intralesional or systemic steroid as first line therapy. We have your beta blockers, your systemic propranolol, topical timolol as alternative. And then if um non-responsive or the results are not that significant, then we perform surgery. So we do laser excision for refractory cases or compromised vision or for those compromised vision. Next would be your congenital corneal opacities. So pediatric in any pediatric corneal opacities, we remember this mnemonic, no? So it's all the conditions combined, no? So for any patients, any children presenting with corneal transparency and corneal opacities, we think of stumped. Could be a sclerocornea, could be from trauma, ulcer, metabolic disorders, Peters anomaly, edema, and dermoid. So we'll be discussing each of them. So sclerocornea, it's also part of your anterior segmentus genesis. It's the presentation. No, so the cornea is having a presentation just like your sclera. So it's scleralization of the peripheral or the entire cornea. Typically presents with peripheral opacity and clear central cornea. So some parts of your peripheral cornea is scleralized, no? So there would be opacification also since your sclera is not is not transparent, no? So your sclera is colored white, no? So there's scleralization of your peripheral cornea. The patients could also have indistinct limbus as compared to a normal patient that the limbal area is really well delineated. It could be unilateral or bilateral and it is non-progressive. So if you see patients if you can see babies or patients, children with deformation or any um, corneal opacity, you assess whether that cornea is of normal size. No? And if not, you may check the curvature, the normal curvature of your cornea if also present. And if not, high likely your patient is having sclerocornea if your corneal curve is around like similar to your sclera. For your trauma, it could be from birth, no, from forceps injury, and it could also be from your congenital glaucoma. May produce tears in the Descemet's membrane, and it is usually unilateral. So we could see this the vertical and horizontal lines. You can appreciate the corneal opacities. There could be a curvilinear lines, could uh represent the traumatic folding of your Descemet's membrane or tears. Next form for your stump is your ulcers. No, you have your infectious and neurotrophic ulcers. Infectious could be either caused by bacterial or viral. So most commonly by your HSV or your rubella virus. Well, history of prenatal infections is usually extracted, and it is also considered with presence of conjunctivitis or keratitis. So corneal ulcer is corneal ulcers are corneal ulcers are also evaluated for this type of conditions. For neurotrophic, the ulcer is coming from a dysfunction of the autonomous nervous system. So your patient had um, less reaction with the nerves of the cornea. So there is familial dysautonomia. The patient's nervous system is the patient's nervous system is not that well functioning. So there's dysfunction, and your cornea is highly uh ideally highly supplied by your nerves, no? So since your cornea is very sensitive, it's the most sensitive part of the eye since it's full of nerve endings ideally. So if there would be dysfunction, there would be impaired blinking reflex, so impaired healing also. So there would be ulcer formation from that. Next would be metabolic disorders or STOM na 'to. Metabolic disorders. So either there are a lot of metabolic disorders now you can think of. So it's variable presentation. It could give you diffuse opacities, corneal pigmentations. You have to you have to work your patient up for systemic manifestations of the systemic metabolic disorders. It's usually bilateral, and it's usually coming from your um coming from your you call this diseases your the term from the diseases that causes your mucopolysaccharidosis and Fabry's disease. It's actually the collective term. I forgot the collective term not lang. Wilson's disease, lipidosis, mucolipidosis, no? So it's the most common metabolic disorders you can find. So mucolipidosis, there's a lot of conditions, no? So you have to remember those biochemistry stuff that you've discussed during your first year. So kind of those are examples of a metabolic disorder. So any lipid or any protein absent from the patient's system, it could potentially cause a metabolic disorder. So your Peters anomaly is for your P, no? So Peters anomaly, it is iridocorneal or keratolenticular adhesions. We further divide this as Peter 1 or Peter 2, but however, for your level, it would be um just be okay if you know the Peters anomaly itself. No, it could either be from iridocorneal, your iris is touching your cornea, or keratolenticular, your your lens is touching your cornea. So there would be adhesions, no, of those mentioned eye structures. So it causes posterior corneal defect with overlying stromal opacity, and is usually bilateral with the central opacity. The size is variable, and the density of the opacity is also variable. It depends on the how the how the condition is being presented. So whether it's at birth or few months after birth, so depende. So it really varies on presentation. Next would be your edema. Your edema is coming possibly from your increased IOP and corneal diameter. There would be ophthalmos or your ox eye, since because of the increased IOP, your cornea stretches, your eyeball really stretches, causing your ophthalmos. No, so there's a relatively larger eye than the usual. It's usually bilateral and uniformly diffused edematous cornea. So your cornea, if it's edematous, it gives off this bluish discoloration or bluish hue. Another condition is your congenital hereditary endothelial dystrophy. It's an uncommon corneal dystrophy. However, it still causes edema, no, corneal edema. It has a defect in corneal endothelium, which in turn has dysfunction of the normal pumps causing edema. You know? So the hallmark for this is increased corneal thickness. Since your cornea is edematous, no, of course, the general thickness of your cornea also increases. The last would be your dermoid. No, so the limbal dermoid, it is a solid benign congenital tumors, uh, mostly comprised of collagen. Frequently arise at the inferior temporal limbus, as the picture uh, is depicting. No, so for both pictures, can see it inferior temporally. These are conjunctival chorostomas as compared to your hamartomas. No? So choristoma, it's not really meant to be there. So contain cellular elements not normally present at location. No, so well circumscribed, elevated, and can appear fleshy to pale yellow in color. So for the management of this condition, especially in those cases that it's really significant, it covers like the picture below, it covers like more than a third of your cornea. Then we then do excision, not to correct astigmatism also. So these lesions are not easy to excise as well, since it is really embedded, no, to the core sa cornea and the sclera. So it's high risk for corneal or globe rupture also. So um we prepare patches of sclera and cornea for this type of excision if warranted. So this is an example, no, of uh removed uh dermoid. So there would be traces of its traces of its insertions, of the of the bed of the sclera and the cornea. So it would leave this whitish scar. Why are we having this? So okay. Next would be the rubella. It's a prototypical teratogenic viral agent. It is a single-stranded RNA surrounded by a lipid envelope, and it is important cause of blindness in developing countries. Vaccines such as your MMR have interrupted the disease, and 5 to 25% of women of childbearing age without rubella antibodies are susceptible. So if you could remember the measles epidemic we had, no, I don't know what age you were then. Basta it happened it happened while I was in med school pa man. So it is around mga 5 to 6 years ago, no, mga anak. So we here in the Philippines experienced that um rubella pandemic, na, so the measles. So the fetus is infected transplacentally, maternal viremia during the course of primary infection. Infection is highest during the first 10 weeks and final month of pregnancy. Rate of congenital defects inversely proportional to the age of gestation. The classic feature would be there would be cardiac malformations, ocular findings, deafness. So those three are the highlights of the hallmarks of your rubella infection. Cardiac malformations, you have to remember this could go out sa board exam. The classic feature for rubella, cardiac malformations, ocular findings, and deafness. Those are most common. So we have to discuss this. For rubella infection, there would be finely stipple bone spicule. There are small black pigmentary abnormalities that we usually describe as having a salt and pepper appearance of the fundus. No, usually the fundus is just yellow orange in color. However, for those patients with rubella infection, if we inspect their fundus their fundus is having the salt and pepper appearance. No, there are pigmentations, small black pigmentary abnormalities, bone spicules, stippled retina. There is also loss of foveal reflex, but vision is typically not affected. Nuclear cataract could also be presented around 15%, and microphthalmia are the most frequent causes of poor vision. Rubella glaucoma is similar to a congenital glaucoma in presentation also. So these are the typical or the usual ocular findings for your rubella. Next would be your congenital cataract. Lens opacities occurring at birth are considered congenital or within the first year or infantile. So if if it's noted at birth, we call it congenital, or if it's noted within the first year, it's infantile. For those having developmental cataract, it is seen in older patients. Um, and those acquired cataracts occur later with a specific cause, like your trauma, your um metabolic disorders, metabolic diseases, your metabolic imbalances, and age-related. Etiology, um, it could be inherited, it's syndrome, it's part of a syndrome, and usually it's undetermined. No? So is it is given that most of the cataracts that most of the cataracts that are present also in patients with systemic or metabolic diseases are those are having a bilateral presentation. So for those patients na having a unilateral cataract, so it could be from either different cause such as undetermined cause or inherited lang. However, if syndromic or systemic metabolic, it usually is bilateral. So if your congenital cataract is less than 3 millimeters in size, it's not that significant. However, if it's greater than 3 millimeters in size, it's already significant. Also, if the patient's age is less than 3 months of age, it's not that still significant. However, for patients with um more than 3 months of age, since your patient or your baby is already growing and visual stimulation is required for your brain visual areas to develop normally. So it also is significant already. So if there is lens opacity that is central or posterior and anything that could obstruct your visual axis, it's already significant. And of course, for patients with very dense cataract, since it it prevents any light from passing um to the retina, no? So it's already visual significant. For the types, the most common is your lamellar cataract. So it is usually bilateral and symmetric. So aside from congenital rubella and dense cataract, you uh, can have your lamellar cataract from your systemic na conditions or from your metabolic disorders. For your polar, it could be anterior, either anterior or posterior. So these are small and non-progressive. For your anterior, these are usually small and non-progressive and rarely require surgery since it's lesser than 3 millimeters in size, no? So it's not that significant. However, for your posterior, it's usually visually significant because it's usually larger compared to your interior and is also associated with capsular fragility since it's highly adherent, since it's highly adherent to your posterior capsule, there would be fragility of your posterior capsule, no, causing fast capsular opacity, and it could also pose great threat when you do surgery. No, it could cause tearing on your posterior capsule. So the treatment as as for all types of cataract, so it's cataract surgery. But for patients, their lenses are soft, na especially at early ages. So as compared to an adult where the lens is already hard, no, so we do just lensectomy. So perform um we perform lens extraction with just aspiration of the lens material only. So the lens need not to be broken into pieces. We usually don't do phacoemulsification since again it's soft, not that hard. And then after we aspirate, we usually create a posterior capsulotomy since the most common complication for any cataract surgery would be posterior capsular opacification. No, so we usually leave your posterior capsule for it to house your intraocular lens, no, your artificial lens. It is where your lens, your IOL, your artificial lens rests man. So for pedia, since they are operated early and growing up, there would be some posterior capsular opacification. No, since we leave the posterior capsule, we sometimes create a posterior capsulotomy. We remove part we remove a part of your capsule, posterior capsule, like the central part of your posterior capsule for the posterior capsular opacity to be prevented. So there would be no capsular opacification already since we already removed the posterior capsule at that area centrally. No? So for those patients that are not cooperative pa, so for children less than 5 years old. However, for those patients na being operated around 5 years and up, we usually omit creation of the posterior capsulotomy since those patients can be cooperative already and we can perform our laser surgeries na lang. So we just uh, aim the laser to the posterior capsular opacities and it will then be removed while sitting. So sometimes um, cataract surgery in pedia is very hard, no? So um, the cataracts are soft, but the procedure is very hard. No, so the implantation of the implantation of the intraocular lens, no, is not that easy. So sometimes to prevent to prevent to prevent from causing further inflammation, we do staged procedures. We then schedule the patient for a secondary surgery to implant the IOL. So we leave the patient aphakic first and um, have the eye medicated to decrease inflammation. And for the next surgery, we then implant the artificial lens. Now, this is to minimize the inflammation that is being um, produced by the manipulation of the intraocular contents. We then provide post-operative refractive correction or refraction correction. These patients are having intraocular lenses at an early age, and the patient's eye is still growing. There would be changes in their refraction. So every time the patient follows up, so we always do refraction, to them to check for their ever-changing grade. So then give the patients glasses also to prevent amblyopia. So we then discuss amblyopia in the next meeting na lang. Next would be your congenital glaucoma. So remember the patient having the large eyes, the ophthalmos, is the most common presentation of your glaucoma patients, no? Your congenital glaucoma patients. So your patients would it is manifested at birth in 50%, 70% in first 6 months, and 80% cases end of first year. Developmental disease with congenital anomalies of the filtration angle, and it is 70% bilateral. There is increased IOP, no, around 30, minimum would be 30, and up, it could range up to 30 to 60 millimeters in mercury compared to the normal na 10 to 21. For glaucomatoscoping, it is also the most important change, emphasizing the need for early treatment. So for this, even if there is still less than 1 year, we perform surgery already, filtering surgery to prevent blindness. So with ophthalmos, there is elevated IOP causing the cornea stretching until 3 years old. So there would be an enlarged eye. Earlier you saw the curvilineal striae, no? So it is caused by the corneal stretching. So leads to corneal edema and of pacification also. So the triad for your congenital glaucoma is patient. You can usually uh see patients having epiphora or excessive tearing. Patient also has blepharospasm, and the patient has photophobia. So past 3 years old, cornea does not continue to stretch already. So your patient's Descemet's membrane could tear up if there would be elevated IOP, not controlled. There would also be scleral stretching and subsequent myopia. So it could be uh, compared to a ball that you constantly put pressure inside. It could it could rupture, no? However, your eye is very stretchable. It could deal with a pressure up to as high as 60 to 80 millimeters in mercury. So, but your eye or your globe would be stretched out. So, giving you this ophthalmos na presentation. So this is the cupping that you heard earlier. The optic nerve is having the disc that is very deep, no, as compared to the the cup, no. There is a high CDR ratio for this congenital glaucoma. So the ophthalmos, the bluish hue, the discoloration, we have striae, the stretch marks on cornea, and eventually the uh, the cornea would then, due to uncontrolled IOP or the uncontrolled pressure, the cornea then will opacify eventually for cases na lost case na siya, mga patients that are already blind, no? So these patients, if there's still visual potential, is lined up for a corneal transplant already since their cornea is already opaque, no uh no chances of clearing up na. When we say juvenile glaucoma naman, it is diagnosed from age 5 to 35 years old. So if congenital, usually from birth up to before the age of 5. So uh, glaucoma are mainly managed through surgery because medical management are usually unsuccessful. So for these patients, after we provide the medical, we then also plan for surgery as well. Since in children, the growing eye stops to development the normal drainage of your the normal drainage of your aqueous. Thus, we do early surgery. So usually the medical managers are usually unsuccessful. Next, for patients having um impaired na ROR, no, or when you when you encounter people when upon picture taking, no, you uh can actually appreciate the red orange reflex. However, for those with a lighter na reflex, no, or those having whitish to orange or yellowish na ROR, you can think of an ocular tumor. So your retinoblastoma. It is the most common intraocular malignancy in children. It is caused by RB1 gene mutation. It occurs in children typically less than 5 years old. And the one that you saw, this is what you call the leukocoria or the white pupil. It's the cat's eye reflex, no? So it's deviated to the normal na red orange reflex, no? It's usually lighter. It's elevated. This retinoblastoma is an elevated creamy opaque mass with a feeder vessel on the retina. We describe it as endophytic if the retinoblastoma is growing into the vitreous cavity, and exophytic meaning exo meaning pagawas, pa posterior. The growth pattern is more posterior, so subretinal. It causes exudative retinal detachment. Endo, the growth is towards inside, so at the into the vitreous cavity, the space inside. Exo, paggawas, more posterior, going outside, subretinal, exudative. Exudative RD. So these are your examples, no? So endophytic, paloob, pasulod, going towards your vitreous. So the tumor is going towards the vitreous here at the inside. And then for those that are exophytic, you can see the vessels, no? The vessels are elevated, so meaning the tumor is growing towards the outside. No? It causes your exudative retinal detachment. It elevates your retina, causing the detachment. So it's an ocular mass. So have to refer these patients to pedia onco. for initiation of chemotherapy. So for some patients that are left untreated, no, you can encounter these kinds of presentation. So there would be bulging of the eyeball until it goes protruding yun out na yun. So if it's left untreated, retinoblastoma can be life threatening. So for this type of tumor, the goals are to save the patient's sight, to save the patient's eye, and to save the patient's life. So that's the three the three principles that we must uphold when treating retinoblastoma. The prognosis tendency to metastasize to the optic nerve and to periocular structures are uh, high. You know, so tumor grows aggressively and patients rarely survive more than 1 year when untreated. Management involves enucleation and biopsy to confirm the diagnosis, and an eye with long segment of the optic nerve. Now, when we do the enucleation, the sample will be sent to the laboratory. So, if there would be, if there would be infiltration of the optic nerve, then chances are it's it could also infiltrate the brain, since your nerve is already connected to your brain. No, so that's why this tumor is really aggressive. No, we usually treat this as soon as possible to prevent fast na spread. For the main management, the eye removal, no, for the enucleation. However, chemotherapy can also we can also lean on chemotherapy with or without radiotherapy to reduce the size for cases that are so large and to kill areas where there are metastases. Some patients undergo chemo before surgery to make the tumor size resectable. No, so depending on the presentation, if the patient's RB, retinoblastoma, is already um going out or so large na, then some would opt to perform chemotherapy first to resect or to debulk for easier resection. Radiotherapy has declined use because of adverse effects to the children. Cryotherapy is used only for small tumors, but rarely done since usually here in the Philippines, patients are diagnosed late. In developed countries in general, the detection of retinoblastoma is usually late. So patients would already present with metastasis, no, their eye is already protruding before the detection. And lastly, for this afternoon, the last topic would be retinopathy of prematurity. This previously called the retinal fibroplasia. This is a vasoproliferative and cicatricial retinopathy seen in premature babies due to lack of abnormal or incomplete vascularization in the retina. It's the leading cause of preventable childhood blindness worldwide. And major risk factors include decreasing gestational age and decreasing birth weight. So if you rotate in your pediatrician for those patients that are premature, no, so you have to take note of this condition, retinopathy of prematurity. Normally, retinal vascularization begins at fourth month of age at the optic nerve. So that's the zone 1 na area. So there would be vascular proliferation in this area, and then it reaches the nasal ora serrata here at around 9 months, at 8 months, and temporal ora serrata at 9 months. The normal retinovascular development arise for vasculogenesis or de novo. So you have your vascular endothelial growth factor. These are the growth factor responsible for the for the growth of your blood vessels the inside your retina, no? So ROP develops in infants who are born before retinal vessels complete normal growth. Or there would be deranged levels of VEGF, no? So in cases there are derangement of the VEGF, then this would cause this formation of these stages, and there would be vitreous hemorrhage and retinal detachment eventually. But first, if there is the lack of retinal vessels in the immature retina, this will then lead to ischemia, and then the ischemia will disturb the normal growth process of the of the retina, no, causing your vitreous hemorrhage and detachment. So we have to be familiar with the stages also, the demarcation line at first, then a ridge is then obvious na, and then third stage would be there would be an extraretinal fibrovascular periphelation or your neovascularizations. Now, as you can see, there is increased vascular formation in this area. Stage 4, this is partial. There's a partial retinal detachment, and 5, a total RD. All of the retina is detached na, from the eye. So per level, it's important to know when to screen patients, no? So this could come out in your boards. So you have to know when to screen. So all babies with birth weight of 1,500 or less should be screened. Also, for patients with gestational age of 30 weeks or below, you have to screen them. For patients with normal weight or AOG but receiving cardiorespiratory support, you still have to screen them since they're receiving oxygen. No? So oxygen could cause irregularities or duration of your vascular endothelial growth factor. So we usually also screen those patients. And also for patients with unstable clinical course, we also screen those patients. First screening should be timed at around 31 weeks of age of gestation or 4 weeks postnatal age, whichever is later. No, so for up to 60% of babies, they are affected. Now, patients screened until retina is fully vascularized or retinal changes undergo resolution. So we let the patients graduate from the retinopathy of maturity screening when there is already noted fully vascularized retina. Due to studies in unique healthcare situations, especially in developing countries, the screening criteria can be modified according to scientific evidence and experience. So this would be different from the Nelson's na textbook that you have in your pedia, no? So if in Nelson's, their subjects are Caucasian babies, no? So usually the birth weight is larger or the birth weight is heavier. No, so for those babies, I think if I'm not mistaken, around or if I could remember still, 2,000 or 2 grams, less than 2 grams ang requirement for the Nelsons. But you have to correlate lang. Okay, in the Philippines, since you're Asians, our babies have a lesser birth weight usually from compared to your Caucasian counterparts, no? So we have a lower birth weight na requirement, no? So you have to compare lang. Kaya I think in your board exam, it will be from your Nelson's man. So take note lang from both the local and international na guidelines. So management, significant number of infants undergo spontaneous regression. And supplemental oxygen could be the causative and restrictive role. As I've said earlier, this can cause derangement of your vascular endothelial growth factors. Um, there's also improved neonatal care. Improved neonatal care has reduced the percentage of babies affected, but has also increased the total number at risk. since part of the neonatal care for premature babies are the supplemental oxygenation, no? So it poses the risk also for retinopathy of prematurity. So for the management, we usually do laser ablation, cryotherapy, and or intravitreal injection of anti-VEGF. So we give the off-label use of the of the anti-VEGF, no? So we inject it intravitreally. Usually, your anti-VEGF medications are given man to treat your gastric cancers man to decrease the vascularization. However, in OFTA, we use that medication to treat the derangements of your vascular endothelial growth factor. So we give um, injections to the eye to prevent further neovascularizations that could cause further vitreous hemorrhage and eventual total retinal detachment. So our OP summary, major risk factors, decreasing gestational age less than 30 weeks, decreasing birth weight less than 1.5 grams. You have to you have to correlate it with the Nelson's, no? So it would be different if the subjects are Caucasian babies. Again, screening should be scheduled around 31 weeks AOG, age of gestation, 31 weeks, or 4 weeks postnatal age, whichever is later. Majority have mild retinopathy or prematurity will resolve spontaneously. Careful follow-up and monitoring for these patients since it could cause retinal detachment and blindness if left untreated. So it's important to know when to screen on your level. So if you graduate as doctors, even if you don't go into subspecialties like into specializations like pedia or ophtha, as general practitioners, you have uh to advocate the screening for retinopathy of prematurity as early detection and early intervention is important to prevent blindness. Okay, so I guess that's the end for today's session. For the amblyopia and the succeeding topics, it will then be discussed Wednesday. Now, so are there any questions pertaining to the topics discussed this afternoon? None? Okay. Are you given handouts for this? Ah, are you provided with handouts?
No, Doc.
No. However, it's ano man, it's on your books man siguro. You have to read na lang the materials or the sources that Doc Martin gave you. No, so I hope you read your book, no, and uh, if you have questions, you can just contact me. Ah, so if none, wala na more questions, then we can end this session. I'll tell Doc Martin lang na we ended in ROP. Okay? Sige, thank you guys.
Thank you, Doc.
Thank you, Doc.
Okay.
Thank you, Doc.
Okay, thank you for listening. Bye.